My name is Henrik Kilonzo, as Mr. Kinoti has introduced, and I'll not go into much details because my bio had most of the information that I would like to share. So today, I am honored. I've just learned this is the first of this year to have a conversation with you who is interested in the lives of mothers and the newborns. Uh, just to take you through what we will go through. We're going just briefly to share about the foundations. And because I work for two foundations, that is Safaricom and M-PESA Foundations. And then we'll look at the context around maternal, newborn, and child health in the two countries. Also looking at the global indicators and also comparing that with the Sustainable Development Goal targets. Then we'll get to module one, we look at what works on the ground, and then connecting community to care, innovation with impact, and then we look at the partnerships that deliver. And then finally, we conclude and have a conversation on the topic. Just briefly about the foundations. We have two foundations at Safaricom, and Safaricom is the leading telecommunications company in Eastern Africa region. And we recently, in 2023, went to Ethiopia, where now we are doing our year 3. So we have two foundations at Safaricom. That's M-PESA Foundation and Safaricom Foundation. M-PESA founded in 2010 and the Safaricom founded in 2003. Both foundations focus on health, education, economic empowerment, integrated water and conservation projects, and humanitarian response. And humanitarian response, mostly in this country, when we have communities in distress, they've always looked at what will Safaricom do? What will the CEO of Safaricom do? Hence, the government 3 years ago, led by His Excellency the President, appointed our CEO, Dr. Peter Ndegwa, to lead the National Steering Committee on Drought Response. We have a footprint in the 47 counties in Kenya, and in Ethiopia, we have the Safaricom Ethiopia Foundation, which is now on its feet and supporting communities. We work and deliver through strategic partnerships with the learning institutions, with NGOs, donors, the national and county government in Kenya, and the regional governments in Ethiopia and others, to ensure that we are able to achieve our strategic investments targets. Definitely as foundations, and because we work with communities, we adhere to what we call ISO 26000 on corporate social responsibility. Now, allow me now to take you through just at granular level now, using what we call an inverted pyramid. Now that I've talked about what we focus on as Safaricom and M-PESA Foundation, I've said we focus on health. And in health, because health is very broad and we are doing so much in health, I'll just zero in into what we are doing around maternal, newborn, and child health. In this pillar, we focus on 3 objectives. The first objective is to increase the demand, and this at the community level. Number 2 is to ensure that we have mothers, newborns get to the facilities when they need support. And then we look at health systems strengthening, working with the county governments, national governments, and in Ethiopia through our partnerships with organizations like AMREF, the Safaricom Ethiopia Foundation, looking at system strengthening. And then the final one is looking at the social determinants for MNCH, which are critical, which go even, which are beyond, during and before birth, during, and even after birth. All this, we focus on our counties and our regions, and we are informed by data. Our decisions around investments, engagement are informed by data. And definitely, we leverage on data and insights and also strategic partnerships, because Safaricom is not a health organization, but we deliver health programs. That's the reason leveraging on other partners' competencies is very, very, very important. And why do we do this? Because it is the right thing to do, and definitely because our purpose is to transform lives. We believe that when communities thrive, definitely businesses will thrive. Hence why we do this as Safaricom Foundation. Now, what you can see, top left is the map of the world. I just want to paint a picture to all of us on where we are. On the right is the map of the world, and I've singled out two countries, Kenya and Ethiopia, and zoomed that out on the right bottom. And then on the right top, on the left bottom, on the right top, that is Ethiopia, the lower side, which has mostly pastoral communities. And then in Kenya is the map of a county called Lamu, which is in the coastal area, which is an archipelago of islands, which has terrible or very difficult conditions to operate in, and which relates to also the situation, the context in the pastoral communities of southern Ethiopia. Ladies and gentlemen, what you can see are real photos of Lamu County in Kenya. We have a market called Mpeketoni. We have a county called Lamu and a town called Mpeketoni within Lamu. In 2014, 2015, 2016, it had terrorist attacks, and development partners, NGOs, the civil society left. And the community was left in the hands of Kenya Red Cross and the county. Nothing was happening. So it was termed as disturbed and insecure. And for those who have worked with donor-funded projects, you know, when a donor labels an area as disturbed, you cannot implement a project there. So it was really, really a terrible situation in Lamu. Maternal mortality went up to 676 per 100,000 live births. Immunizations complete were 53, and skill deliveries were mere 64%. In 2016, as Safaricom and M-PESA Foundations, we made a decision. We get to Lamu, we work with the security system to ensure that we dignify the lives of people in Lamu. We went down and co-created a program which we call Uzazi Salama, or Safe Motherhood. We co-created with the county, with the community, and the first priority was to strengthen or to revive the community care system. That is the community health workers then. Now we call them community health promoters. And as we shall continue, and I shall continue to tell the story, in 2022, by addressing the demand in Lamu, by addressing the referral in Lamu, by addressing the human resources for health in Lamu, ensuring there is an act that supports the community's healthcare service delivery, and then bringing in other partners, using technology to identify and enroll each pregnant mother, we were able to significantly drop or contribute to the drop in maternal mortality, which now is at 305 per 100,000 live births. I'll be able to expound on that. I now tell you the story of a lady called Emebet. Emebet is a 26-year-old lady in Ethiopia. She's pregnant, and this is her third pregnancy. The clinic where she goes is 3 hours away. Sometimes when she goes, there is no nurse. In fact, she did not complete a maternal profiling when she went for the first ANC. So that's already a danger there. The question which Emebet asks is this: when she will be in labor, think, and we all know, those who are in health, we know most births happen at night. Who will save her life? Because in case of any referral, the next health facility is 17 kilometers away. That is the story of Emebet. If you compare with Amina in Lamu in Kenya, we revived all the systems, we bought water ambulances, we strengthened the infrastructure and the equipping and the county employed staff, different contexts, different levels or rates of survival in case of any emergency. We always say, ladies and gentlemen, when data speaks, we listen. And I will also even say, when quality data speaks, because we know garbage in, garbage out, we listen. This data tells us, one, in Kenya and in Ethiopia, maternal mortality is still higher despite the investments that have been done by the different governments, donors, and other partners. When you look at the data, and that's not presented here, and what, just as a disclaimer, because I'm talking to even other scholars, I purposed not to present anything academic because I know I'm talking to the experts. You can correlate, you can regress, but I will not be talking about all that. I'm talking about real experiences and learnings in the field. While when you look at this data over time, it's been significantly improving, but mothers and newborns are still dying. And what can we say? Yes, we may have a lot of coverage, the whole of Ethiopia, which has been doing very well, and despite the difficult circumstances, and the whole of Kenya, for example, coverage alone is not enough, or it's not the solution. But as we shall see, the quality and the continuity of care are very, very, very important. I'm still asking, and it's a question, a rhetoric question I still ask you. Why are we having our mothers and the newborns still dying? Why? We group, and based on our experience and our co-creation in Kenya, we group this into the 3 delays, which is not new to all of us. The delay for families, households, mothers, their husbands, to make decisions to seek healthcare in time. When they have made the decision to seek care, then they get to the delay in reaching a healthcare facility or healthcare point. And then when they get to the health facility, the delay in receiving quality and adequate healthcare in time. Those are the 3 delays that significantly contribute to mothers dying and newborns dying. And in our interventions, we've co-created interventions to address this. Now, when we go to the first delay, it's about awareness creation. It's about culture, and it's about the gender norms, which we are all subject to. And we talk about the reaching care. It's about the geographical differences, hilly places, floods, insufficient health facilities, among many others, and even the cost of accessing care. And when we talk about the delay in receiving adequate care, is about our facilities ready? Do they have skilled staff with the right attitude? And they have supplies and other essential commodities, which are critical in addressing the health of a mother and a newborn. While we are working, we have identified some of the critical factors or reasons why we're still losing our mothers. In addition, now, and I'm unpacking now the 3 delays model. And I'll not take much of your time because I know this is music to your ears. Postpartum hemorrhage is the leading cause of maternal deaths. Why? Because of distance to facilities, lack of blood. In Kenya and Ethiopia, most of the places, they have to depend on other centers, for example, to access care. Now, we have over 60% of our maternal deaths, and I don't know what your experience is, occur in referral hospitals. And these are high-level facilities. Why? Because mothers and newborns are referred too late. If the lower facilities are able to handle, then we'll be having fewer referrals. And by the time they're even being referred, they have already gotten the necessary support. Then we still have, deliveries being conducted by traditional birth attendants, lack of oxygen for newborns before, during, and even after birth is also a leading killer of our newborns. And then definitely human resources for health is also a critical contributor to this. And then definitely weak community health systems about awareness creation, influencing behavior and the cultural practices at community level. And then definitely, when you look at the two regions, the southern part, the pastoralists, even in Kenya, in Lamu, and even other regions within the two countries, high teenage pregnancies. And why is this an issue? Because the bodies of these young sisters, young daughters, are not ready for pregnancy. What means they have high risk and also risk of developing a fistula. Now, ladies and gentlemen, let's now get to look at really what has worked or what works on the ground. And this is now addressing module number 1. We have learned that for us to have any impact, working in silos cannot give us results. Integrated approach, which is co-created with the relevant stakeholders, will give us results. And this is, for example, using data for precision programming. And we use the word precision programming just to ensure that we are not doing a waterfall approach. We only address what is critical. We provide the service, particular service, that will contribute to saving the lives of mothers and newborns. It's about health leadership from the national governments, regional governments, and also the county governments. It's about working with community health promoters. For example, here in Kenya, the health extension workers in Ethiopia, to find and link and retain the mothers until they deliver, even post-delivery. And then the more secular engagement, where we have them coming to address system strengthening, research, commodities, and others. And then definitely health infrastructure, which is critical. This is important because of addressing delay number 2, reducing the distances. But health infrastructure alone cannot help the mothers because we need them fully functional and within reach. Then bringing in innovations. For example, in Kenya, we are doing what we call the roving laboratories to ensure that we are not losing mothers, or mothers do not miss the MCH profiling. We also have what we call Binti to Binti, where we've brought together young mothers, teenage mothers together and linked them with senior mothers for mentorship. And then definitely research, and then working on the scale-up strategies and also addressing social determinants. So we cannot just isolate one, but we need to have an integrated approach, leveraging on partners' competences and areas of interest. Now, on what works on the ground, the community health promoters in Kenya and the health extension workers in Ethiopia are the foundation of MNCH or healthcare at the community level. They are trusted, they live with those communities, and they are available to support. In Lamu, we identified all pregnant women We registered them in a platform which we call Uzazi Salama platform. We followed them until accompanying them to deliver in the health facility. In fact, in 2018, I was registered as a pregnant mother just to ensure that I am tracking the functionality of the platform. After 9 months, I delivered. Don't ask me the name of my boy or child. And then my boy and or girl was monitored, and I was also monitored until 24 months, just to ensure that I'm reminded of immunizations. If I'm not going, then the community health promoter or the extension worker comes for me to ensure that my child, my newborn, is able to access all the services. So working with the local system, working with community health promoters, working through health education workers ensures no one is left behind. And the success of the community health promoters and health extension requires incentives. Unfortunately, most countries, even in Kenya and Ethiopia, Kenya, they are getting an allowance which is paid for by the national government and matched by the county governments. In Ethiopia, the health extension workers are trained for 1 year and they're on salary. But they're also backed up by what they call the community health volunteers army, which is also, they are volunteered and they're not salaried. But when you look at even what they earn, it can't do much. Still, we need to do more to have community health promoters and community health extension workers well appreciated or paid. So when there are clear protocols and they are valued within the system, definitely they are able to address and ensure that we're able to identify all the mothers who are pregnant, walk the journey with them until they deliver and even post-delivery. Number two, addressing delay number two in connecting community to care. We have identified the mother. In Lamu, we identified all pregnant women. Ethiopia, through AMREF, supported by the Gates Foundation, USAID, in the southern region, identifies, through using the ComCare platform, identifies all pregnant women, identifies where they live, registers them into a platform. So you have them. And then through reminders for their ANC, reminders on what they need to eat, reminders on kind of nutrition, reminders on the next clinic and all that. 9 months or EDD comes. How do we get them to the facilities? Because we do not want them to deliver with support from a health worker, to traditional birth attendant. So what we did, for example, in Lamu, we incentivized the community health volunteer, now community health promoter, that every mother that you ensure delivers, there is an incentive. That's number one. We also had a kind of a competition where the mother who refers the majority is also acknowledged. We facilitated their communication in terms of airtime, because definitely working with Safaricom PLC, airtime, bundles, we gave each community health promoter a phone, and then which was loaded with the platform. So there was no issue of I never had airtime, I never had bundles to communicate about this mother. Then referral. And referral here, ladies and gentlemen, referral is not about getting the mother, just transporting the mother to the facility. No, that is not. That's just transport. So what this means is there is communication from the mother to the CHP to the next facility. And even after the mother delivers, there's also communication about so-and-so has delivered very well. Baby and mama, okay. Now the community health promoter continues to support that mother to ensure they close the loop. So it's not just getting Amina from point A to point B, or Emebet in Ethiopia from point A to point B, but it's a loop that needs to be sustained. Definitely, what you can see on your right is what we call in Kenya mama packs. The mama pack has what the mother requires for her and the baby immediately after birth. It has what we call the kanga, it has the leso, it has the baby clothes, it has soap, it has it has a blanket for the baby and other essential items. When you go to the communities, and I single out Lamu in Kenya, I single out Somalia in Ethiopia, I single out Samburu in Kenya. Mothers, when they realize they are pregnant, they go to the facilities to book this mama pack. In Ethiopia, we call them the dignity packs. They pull mothers to the facilities. And what does that mean? It increases the number of mothers delivering at the facilities and also contributes to the reduction of the risks. Now, we have what we call the non-pneumatic anti-shock garment. Borrowing this, that's the second photo from on the right, just in between the two. This is borrowed from the US and their space experience, NASA. And when you look at studies, NASG can save up to 80% of blood loss by just ensuring that all the vital parts of the organs of the body receive what? Receive blood. We are using this in Kilifi, in Narok, and we have the experience. It operates like if you use what we call the crates of soda or water. You take your water bottle to the vendor, you leave yours, and then you go, or gas. You leave what you have. When you bring the mother with this, they give you another one. So at any one time, the ambulance has this key gadget. And then we are also ensuring that any mother who develops fistula or who developed fistula even before we started our interventions in Kenya, as fistula repairs, we restore the dignity of women and girls. Because this is a disability, maybe because of prolonged labor, because health facilities were not there. Mother could not get a CS, or referral was done late. But we are coming in to do that. We have quarterly fistula surgeries in this country, and we are working with AMREF, who are also critical partners in Ethiopia, to ensure that all cases which are identified are referred to the necessary facilities for support. Now, ladies and gentlemen, as we make mothers move from one point to the other, referral is not one-off. I talked about it. It's a loop. Digital tools which are used to refer save lives. Workflows, they don't save lives, but workflows save lives. Let's continue to incentivize our mothers to deliver in hospital facilities. The mama pack that you see costs approximately 4,000 Kenya shillings. And that's like, you can convert that, you'll get very little. Allow me to talk about the water ambulance that you can see. I talked about Lamu, which is an archipelago of islands. Water transport is very expensive, and communities cannot afford. From the Lamu Island, for example, where the hospital we call King Fahd is, to a place called Kiwayu, is using a normal boat is 3 to 4 hours. Imagine a mother bleeding. Imagine a mother in labor, in the ocean, on a normal boat, what that exposes her to. So we worked with the county government of Lamu and bought them a well-kitted water ambulance. And we put in 2 engines, and a distance of 4 hours, this boat does in 45 minutes. Imagine the number of lives we have saved. The county government came in and they meet the cost of maintenance, the human resources, and that's from partnerships that work. You go to Lamu, if you are from other countries, when you come to Kenya, get to Lamu, go and experience this transformative innovation around transporting mothers on the ocean. Now, I just want to briefly talk about care at the facility. Definitely, infrastructure alone will not save lives. We need these facilities to be accessible, and that's the reason we are funding and working with partners and the county and national governments and regional governments to ensure access to facilities by building maternities and the newborns, but not just the 4 spaces, ensure that they're equipped. We, for example, have been partnering with the Clinton Health Access to ensure that as we design the newborn unit, it follows the government standards. Does it have oxygen? What is the client flow? And what kind of critical equipment does it have? And as M-PESA and Safaricom Foundation, if I can give an example, we have supported even referral hospital to establish their first newborn critical care unit, which never existed before. So infrastructure is very important. Supplies and the commodities, this is the responsibility of the national, regional, and the county governments. And then, of course, human resources for health, and also training health workers on task shifting to ensure that it is also supporting the challenge of human resources for health. For those who have been, for example, in the world of HIV and AIDS, you realize around 10, 15 years ago, we started talking about task shifting in terms of managing the treatment of persons with people with HIV, where, for example, a clinical officer can review a patient who comes for treatment instead of waiting for a medical doctor. And we have published cases on the importance of task shifting. Ladies and gentlemen, we've looked at the demand, creation of demand. Community health promoters, community health extension workers are critical and they need to be valued. They are an asset. Referral is not just transport, it is a loop. And then now the facilities need to have the right equipment, the right staff to ensure that services are provided in time so that they don't become danger zones for our mothers and the newborns. Now, let's look at, for example, based on our experience, what kind of innovations have we had? Now, at Safaricom, it's a technology company and looking forward to be the leading technology company in Africa by 2030. We funded AMREF, who developed the LEAP platform, which has been used in Ethiopia for many years. In Kenya, it was very successful that it became a social enterprise. And I'm now talking to the techpreneurs here or the health entrepreneurs here. So through funding to AMREF in 2015, developed the LEAP platform. And the LEAP is just LEAP. It's not an acronym, ladies and gentlemen. This in Kenya runs as a social enterprise, making money for it to be improved, and whatever they make, they plow back to do more. A very good platform for training of community health workers, health volunteers, and promoters, health extension workers. And this has been used in both Kenya and Ethiopia. ComCare, that drives the EHS in Ethiopia, does the registration, the monitoring, the tracking, the training, the advisory, the flagging of any flags as far as the pregnancy of the mother is concerned. And then we have now Zazi Salama, a platform at Safaricom and M-PESA here, which we are using to register or identify all the pregnant mothers and even the newborns after delivery. There are so many platforms, even in Ethiopia. There are so many platforms, even here in Kenya. But I just thought of singling these 3, that with the right platforms, with the right applications, we are able to have the numbers of the pregnant mothers that we have. The pregnant mothers who are in whose pregnancy is in danger. The newborns after delivery who are in danger. Flagging everything around their health, and also reminding them ANC, EDD, and also immunizations. And even nutrition on what they need to feed, what they also need to feed their young ones. So many, but the opportunity for us here and those who are in tech, those who are in entrepreneurship, is looking at what are the opportunities around, the health, the MNCH ecosystem, and what are the opportunities to solve a problem. And as we say, let's not focus on the platform or on the technology. Let's look at the need first. In other words, what are we solving for? Once we identify a community problem, then the other resources will come in. So we don't go to, I want to make money. No, I want to solve a community problem. What is that health problem that I want to solve? So with these platforms and applications, we have data in our hands. We have data that we can make decisions. We can call, we can text, we can refer. But let's also know that we have learned that these digital solutions, they don't replace people. They just empower. They are an enabler. And then they do proper connection, and they create a continuous, coordinated safety net around every mother and a newborn. Ladies and gentlemen, I want to briefly talk about data for action and predictive analysis. If there is an area where, as Henry, I have a lot of pain points, is in this area. In the sense that, number one, every day, data is collected from households. Maybe because the government wants it, maybe through health extension workers, or maybe the donors want it, or name it. But it's collected for accountability purposes. In very few cases, and you can look at available research, very little feedback gets back to the households. Collection of data is for accountability purposes, but the feedback loop down to where it came from, in simple language, that is missing, even when you look at available knowledge. Now, I give you an example of Lamu. In Lamu East, which has low literacy levels, and also that's where the islands are, low literacy levels, and also poverty levels are high. We identified that region based on data that, immunizations were very low. What did we do? We had targeted interventions for a particular region based on the data that we had. And because the other regions were also doing well, when you look at the overall impact, when we started in Lamu, immunizations, we are at 64%. But in 2022, when you look at the demographic health survey report, it was at 82%. The same happened with skill deliveries. When we started at 53, by the time we finished, we had 92.5% when you look at DHS of 2022. However, I just want to emphasize, ladies and gentlemen, utilization of health data is a major gap. And that's an opportunity for the stakeholders here, for the practitioners here. How do we position ourselves as, people who are interested in health to really address this gap? When you go to Ethiopia, in Kenya, you find data utilization mostly happens at higher levels, the managerial level. But now when you go to the lower level managers, officers, there isn't really much of evidence of data use for decision making. Yet, quality data exists. That's an opportunity and a challenge to all of us. How do we develop the culture of data use for decision making? That's very, very critical. A culture of the health data use for decision making. Could it be opportunities around developing of the different platforms, social enterprises, around data and analytics and all that, so that we are not just using data to report, but we are using data to even talk about tomorrow and how we can prepare ourselves for tomorrow. That is when data will provide more value to all of us. Now, when I just when I look at the audience in here, and based on what we do, I ask myself, what are some of the opportunities? What are some of the opportunities for any health entrepreneur or techpreneur here? I talked about building of digital health solutions. And this is about getting to the ground, living with the community, understanding their pain points, and getting solutions to their problems. And then we have telemedicine platforms. Definitely, this is an area which governments globally have a lot of interest in. In Kenya, as we speak, we are able to get children from northern part of this country, from Lamu, get pediatric support from Gertrude Hospital here in Nairobi. In Ethiopia, which is also doing very well, mothers, women are able to get support from the Somalia region and getting support from experts in higher level hospitals. This is critical. We are now scaling this, for example, to now include other surgeries services within health facilities, where doctors, pediatricians, or gynecologists, or even general surgeons can be able to get that technical support from other experts in global. We are doing this in Nairobi here, in Kenya here, through our medical camps, where we are getting oncologists from India to support our communities through telemedicine, real-time conversation, review of reports, and all that. So this is an area where we have a lot of opportunities. And Ethiopia is doing very well. Kenya is also doing very well. But both countries, definitely, we still have a curve that we need to cover. Service delivery still remains a gap. And that's the reason you'll find NGOs coming in to support civil society coming in to support government, donors coming in to support government. But we still need to innovate around this. How do we improve services in our health facilities? Then improvement of the health supply chains. Allow me to give you an example. I've traveled to a very remote place here in Kenya, and I was talking to a medical officer. The chart which they displayed, the second leading killer of people in that region were snake bites. And I asked her a question. Why? And she shed tears. And I asked her, why, doctor? She said, I do not have supply of antivenoms, or I do not have consistent supply of antivenoms. That's about supply chain. And if I refer, the next facility is 2 hours away. That's such a long time to save somebody who has been bitten by poisonous snakes. We can talk about examples in blood supply and availability to save mothers. We can talk about supply of oxygen to save newborns, among many others. Opportunities around that. Then health financing products. This is an area where or lack of financing or poverty, if I can use that, within the households is really ensuring that is really contributing to people being left out. While we want to have everybody, in the loop, from government financing to private sector and the others. So what are some of the innovations that we need to have? They can be from a digital technology perspective or from non-digital perspective, because technology is not digital. We also have technology without, digital. Then what I know may be most exciting to many techpreneurs here is about how do we turn health data into insights? And you can, identify the issues, and then now the rest will fall into place. Quality data, the insights. What is that informing the overall health system in the respective countries? So the major gap here, and here I'm talking about challenges and also what we've learned. And my interest mostly is about the challenge, the gap, which I challenge all of us here to rethink through this. It's about how do we make use of data, health data for decision making. And then strategic partnerships that deliver. In Ethiopia, the government of Ethiopia, AMREF, the Gates Foundation, the local NGOs, USAID then, delivered a very great program which saved thousands and thousands of mothers, as you can see on this slide. I don't want to get to the numbers. In Kenya, when I started, I talked about Lamu and how through co-creating with the county government, we're able to improve, to contribute to the reduction of maternal mortality from 676 per 100,000 live births to the current 305 per 100,000 live births, and then the other MNCH indicators. Now, working alone does not give sustainable results. If we are able to sit down, identify organizations, stakeholders, where we meet, who also meet or are aligned with our strategic approach, and we look at what they can be able to bring on board, and we co-create without leaving the government, either regional government or the national government or the county governments. To me, that is the best way to start an MNCH program and ensure that we have sustainability prioritized from the start. And as we say, the best of the projects disappear in government. What does that mean? We co-create with the government from a system strengthening perspective. By the time we are finishing the project or program, is already got into the government system, the exchequer is taking care of it, and then we move to the next. But where you find each and every time, then there is a problem. Definitely, we know in Africa all the challenges that we face around, government indicating that they have no money, they need funding, and all that. But definitely, even if it is to continue being implemented, let's look at where do we integrate or how do we integrate with the government systems. To me, that's the best. But also looking at the role of each of the partners. Here just picked at high level what the role of the government is, the higher learning institutions, the private sector like where I am, the civil society organizations, donors, and also the community, and emphasizing on the community. A Chinese philosopher said this: go to the people, live with them, love them, know what they love, and when all things are done, they will say, we did it ourselves. What does that mean? I've just paraphrased. We go to the community and learn from the community. So that's not top down. Get to the ground, learn, live with them, love them, co-create with them. Finally, they will own it. The same, and this based on our learnings, is also when we involve the government in time, so that they're not just recipients. Remember, health is a government responsibility. Could it be government, national or county governments? We also to get the civil society organizations, and definitely not reinventing the world. It's just contextualizing. We contextualize based on that particular region, that particular community, and ensure that systems work, but not just copying what works in Somali, for example, or the Oromo region, and putting it now for example, to Lamu side, or moving Lamu to the northern Kenya. Totally different contexts. Same country, different people. So we need to live with the people, understand. I'm just emphasizing the role of the community, so that they're not recipients, but they're also part of the identifying of the solution. Through the more than, you can say, combined more than 25 years, but specifically looking at our Uzazi Salama project, which we've been running for the last 2013 to today, there are some key lessons that I want to share. Trust beats infrastructure. What does this mean? Trust takes time to build. So if community health workers, or if the community members trust the health system, they'll go to it. We will not even create awareness. And this is a critical software for the health workers in the different facilities. And through our different engagements, working with the county health systems, the national systems, to ensure that the software around people are addressed. That's how trust is built. And also trust that when I go, I'll find the nurse, I'll find the clinic officer, I'll find the medical doctor, I'll find the drugs, I'll get the services consistently. That will build trust. Continuity beats coverage. And this is about quality issue. Quality issue. Continuity of care. It's not just about we've covered the whole country, but what about tomorrow? We should not just dropping, an event, but there is continuity, there is follow-up. And then workflows beats technology. As we said, technology just an enabler. But how is the work flowing from the demand side to the facility side, or the demand and the supply side of it? Quality beats access. And that one, I don't need to repeat. It can be accessible, but the quality is poor, which now affects the trust the communities have in the health system. Ownership, I've talked about it through co-creation, working with the right stakeholders, engaging them so that they are part of the conversations from the start. This is critical. And these are critical 5 lessons that we've been able to learn. So ladies and gentlemen, as I conclude, maternal and newborn deaths are not a technical failure, as we've seen. It's a systems failure. And as we know, a system works in harmony. So if there is a break in any of the parts, it's just like a chain. Systems can be redesigned. And this is the opportunity that we have. And this is the opportunity that we have redesigned. We started in Lamu, for example, and the issue of maternal shelters never featured. We were in Samburu, in the northern part of this country, a community which have their own maternal shelter where the mother says before they go to deliver. We have to bring in this so that we are relevant. There are communities where, for example, as you incentivize the community of the volunteers with bicycles, you realize, culture here dictates that no woman should ride a bicycle. What do? You not give them a bike, but what else? How else can you incentivize them? This can be redesigned to meet the specific needs of that community. And then every scholar here, or a practitioner, or a partner in this conversation, I seek that you can do 3 key things. 1, strengthen community. Let's strengthen community health workers or community health promoters. They are critical. And both governments, Kenya, which has more than 100,000. In fact, Kenya has 107,000 community health promoters. Each community has a phone, has a bag which is kitted, and they're getting allowances. Ethiopia has more than 40,000 health extension workers who are trained and they are paid, but they're supported by the army, the community health promoters army. We need to strengthen that because they are with the people and they are trusted. We need not just to transport mothers, but let's look at a referral loop so that we are not just transporting, but we are with the mother from the start. We are communicating. We are getting her to the facility. We are following up post-delivery until all the critical boxes around complete immunization, nutrition of the new one are ticked. And then use data for action, not reporting. I talked about this and I will not repeat, ladies and gentlemen. I thank you all.